Good afternoon, everyone. Very pleased to be here. And it's actually, the fortune is mutual that we linked up with Duke University, specifically PGH, Asha. So, what in the next about 25 minutes or so, what I'll try and walk you through is the kind of work that Asha and my organization, where I'm based, is involved, and the number of collaborations that are developing, and the kind of work that we're doing. So, talking about maternal depression, Karen just now was telling me about the nursing staff that gets to interact. So I just hope that you also get to relate to what I'm going to be talking to you about. So it's more public health. It's trying to prevent. It's trying to deal with populations at scale. So that's the crux of the kind of work that I've been involved in since the last 10 years. To set the ball rolling, let me give you a snapshot of what maternal depression or perinatal depression across the globe looks like. So if you concentrate here, so this is Pakistan, where I'm based, where all of my work has been based since the last 10 years. So it is amongst the highest in the world. So what does this do? I'm sure through your clinical practice, through engaging in the communities, you would have a good idea what maternal depression leads to. So it has its effects on the mother herself. So, of course, social functioning, increased productivity, negative thoughts, suicidal ideation, and many a times leading to suicide, maternal mortality through depression. What does it have as an impact on the children? So you name any child health outcome, starting from prematurity, low birth, stunting, malnourishment. So we have ample and very robust evidence that it is an independent risk factor for all child health outcomes. So it's kind of a double whammy. So the maternal, perinatal, mental health not only affects the moms themselves, but also the children. And just to give you a context from where I come, Pakistan, in the rural settings, every fourth woman is clinically depressed. So every fourth newborn child is being raised in disadvantage. So raised in disadvantage, I really like this this graph. So if you, so this is basically gives you the life course trajectory, health-wise, from 0 months of age till 5 years of age of the child. And what are the downwards and upwards forces acting on this trajectory? So just concentrate on the poor trajectory, which is represented by the red line. And if you see, so there is this toxic stress that keeps pushing this trajectory downwards. Another one is lack of health services. So please keep these 2 points in your mind when we walk through the rest of the presentation. Looking at this life course trajectory, the burden of perinatal mental health, maternal depression, no wonder maternal depression has been labeled as a global threat for child health and developmental outcomes. A grim picture. So one should ask, what is out there to help this? So fortunately, there are a number of interventions which have shown good effect sizes. One of them has been the Thinking Healthy program, which was developed by Professor Atif Rahman, who's one of our collaborators. He's based in University of Liverpool. He's a professor of child psychiatry. So about 10 years back, he developed this intervention which showed one of the largest effect sizes. This was delivered in the communities through non-mental health professionals. So this was called the Thinking Healthy program. It had 16 structured sessions delivered through community health workers in Pakistan. The community health workers in Pakistan are called lady health workers who do primary health care. They look after the antenatal, they register antenatal women, take them for antenatal checkups, postnatal care, vaccination, family planning. So promotive, preventive work, that is their mandate. So this Thinking Healthy program was delivered through these lady health workers through 16 sessions, starting from the third trimester, antenatal period, lasting till the 10th month of infancy. And it was a cluster randomized controlled trial, got published in the Lancet. It had very good results in terms of huge effect sizes on maternal depression outcomes. We also saw some health outcomes related to the child. For example, the mothers who were intervened were more likely to have the child's vaccination coverage done. The mothers who were intervened had less likelihood of their infants to have diarrheal episodes. The mothers who were intervened, along with their husbands, started playing and spending more time in learning through play activities, spending more time as a unit. So there was some indication that we had an intervention which had some footprints left in the early child developmental area, which we could perhaps think that in terms of the trajectories, what would be the long-term outcomes. So since it had a large effect size, and I'll show you in the next slides how this Thinking Healthy program started featuring in many of our community-based programs for early child development, etc. And recently, this has been taken up by the WHO as one of the low-intensity series of psychosocial interventions. So we are very pleased that this has been taken up for global dissemination and global testing in different settings. So I was just talking to you about having those small imprints seen when we followed up the original cohort of the Thinking Healthy program, where we had our last follow-up at 12 months of postnatal period, so infants, 12 months old. Then Duke University, Asha, and myself, along with a number of other collaborators, Professor Atif Rahman, we went to Grand Challenges Canada, got a grant to re-enroll those trial participants, that cohort, which we had left at 1 year of age, and follow them up 7 years down the line, just to see what that early intervention led to. Did it do any improvement in the cognitive development, the social emotional development, or the physical? So we recently finished and we recently published the results in Lancet Psychiatry. So what did we find of this long-term follow-up of an early intervention? Hoping against hope, we were hoping that those early imprints would have a long-lasting effect. Unfortunately, we didn't see any socio-emotional or cognitive development or physical significant differences between the ones who were intervened or the ones who weren't intervened. I'll take a pause here and I'll shift gears. If you remember that life course trajectory, where there was this toxic stress, as well as poor or lack of health services. Now here's the context in which I work. Having seen the long-term follow-up, no effect seen in the long term, Poor health systems, from where I come, the lady health workers, the community health workers, they are community-based workers. They are the first line of contact. They're already overburdened. That's a challenge. The literature says that perhaps targeting certain biological time points early in the antenatal period and as long as 1,000 days. Yeah. So our intervention was just till the 10 months postnatal. So we missed that mark as well. And then we know, I just showed you a slide, that it's a low intensity psychosocial intervention. Yeah. Delivered through non-mental health professionals. So longer duration, longer sessions are needed perhaps for such low intensity interventions. So how do I scale up known evidence-based interventions with all these constraints? So as I see it, as my group sees it, there are a couple of three barriers actually for scaling up such evidence-based interventions. One is this human resource. So let's look at what sort of a barrier is this? What is it that our group is doing to bridge that gap? This is just a snapshot of, again, just to let you know what the human resource spread looks like in the high-income countries versus the low-income countries. Again, just to give you a better context, I trained as a psychiatrist. I live in Pakistan, which has a population of 190 million. Guess how many psychiatrists, including me, for this population would there be? Any wild guess? 25. No, that's just... We're slightly better than that.
Okay, you're better than that.
Add another 400 to that. So 425, including me, for a population of... So the treatment gap is enormous. In one lifetime, I may never be able to see the caseload that's cut out for me with that kind of numbers. So what do? Knowing that this is a finite resource, so we have to look beyond the professionals, mental health professionals, go to non-mental health professionals. One example, Thinking Healthy program, delivered through lady health workers. So we have to start looking at non-mental health professionals. Yeah. So we know they're a finite resource. In Pakistan, the lady health workers at the moment, they're stipulated, cut out, mandatory things that they have to do, list down to about 25 things. So how do you then expect that they will also toe the mental health agenda, also toe maternal depression's agenda? So that's slightly not possible. And as an example, you just saw, we didn't see a long-term effect to the lady health workers because it needs to be perpetuated. Low intensity interventions need longer duration. Yeah. So I'm stuck. So what do I do? Yes, Karen. This from the field. Sorry, that's how we load our trucks back to Pakistan. Yeah. So
it's a lady health worker.
Exactly. That is. I was driving off the field, and one day I saw this truck, and I thought, is this a truck? So instantaneously it reminded me of the lady health workers. They're bent out of shape. They've lost their original work that they were cut out. They were actually meant to do family planning. They're doing TB, they're doing malaria, dengue, they're doing antenatal. So you name anything. So they're doing everything except what they were cut out for to do. So you can't recognize now what lady health worker program is. So coming back to this non-mental health professionals, lady health workers or community health workers are a finite resource. So what's the answer? So we got funded. We hold one of the global hubs funded by the NIMH. So with Professors Atif Rahman and Professor Vikram Patel, we hold the South Asian hub. and Human Development Research Foundation is one of the leading organizations to conduct the research component of this hub. This hub is called, the acronym is SHARE, which is South Asian Hub for Advocacy Research for Mental Health. Yeah. So what we did was, we took this Thinking Healthy program, which was originally delivered by the trained lady health workers held by the government. So we adapted this intervention for delivery through peers, volunteering to support mothers in the same community which they reside. So, Ed Fisher is sitting there, who is a leading person who's running a program, an initiative called Peers for Progress. So we got inspired by this idea. So peers have been used for decades to do many things. And if you look at South Asian culture and history, so there is a very rich tradition of women supporting other women during childbirth in the first 42 days. Yeah. So other women in the house resume childcare, let the new mom sleep. They make lots of high nutritious nuts and foods. So she's given some respite. So working on that premise in this South Asian region has a rich history of supporting other women. So we adapted the original Thinking Healthy program for use and delivery through peer volunteers. This is currently being tested in two diverse settings, one in Pakistan, which is rural, one in India, in Goa, which is urban. So through peer volunteers, with no salaries given, but some non-monetary incentives like encouragement, certification, giving them some travel allowance to keep them engaged. Because one of the meetings 5 or 6 years ago I attended with this Peers for Progress from 7 continents, people with experience, only 2 things came out. That was my interpretation of that meeting that I attended. One was how to keep these people motivated. Yeah. The other was how to link them up with the existing health systems. Because you can't have a parallel health system running. That's not sustainable. It will die out at some point in time. So we think in this South Asian hub that we have, in which we're testing out the effectiveness and the cost effectiveness of this Thinking Healthy program, which is now delivered through peer volunteers. Yeah. That's the innovation. They are closely working with the lady health workers, collaborating with them as their task sharers. So they help them organize their monthly groups for the women. So in Pakistan, this Thinking Healthy program is being delivered through one-on-one as well as in group format. And we're just about finishing our recruitment phase for that particular trial. Now, learning from what we saw in the long-term follow-up, which Asha, along with me, did. So we thought that let's follow up this this neat cohort that we have in the form of SHARE trial. Yeah. So Asha developed a grant. She got funded from the NIH to follow these SHARE trial participants and their infants till 36 months of age, as opposed to from what we learned from the previous project that I was saying, there were lots of gaps. We didn't follow them up for good 6-7 years in between. We didn't know what happened. So this gave us the opportunity, SHARE Forum gave us the opportunity to follow these women up for a longer duration of time. So we plugged in all the gaps, what the learnings were from one project to another. So these days, and again, before I tell you about the details, this is the list of the team members. So lots of people Karen, Elizabeth, and then Columbia University, Lisa Bates, University of Liverpool, Atif Rahman, and then Human Development Research Foundation. So what we're doing is we're trying to follow these trial participants, share till 36 months of age. We've also developed and my apologies because this is work in progress, so this is all Urdu script. But what is this? This is that low intensity intervention held and given for a longer duration of time. So we've developed this peer-delivered Thinking Healthy program for group format delivery, but till the 36 months of age. The shared outcomes that ends at 6 months of postnatal period, but for shared child or the Thinking Healthy program peer-delivered plus ends at 36 months. And all the outcomes, cognitive development, socio-emotional, maternal depression, support, etc. So we are also simultaneously recruiting for shared child, and we have this intervention ready to be rolled out. And we'll keep you posted. The English version, once the Urdu version gets finalized, so we'll have our English version as well. So these are just some snapshots of what the groups will look like. So it has lots of things, narrative-based, story-based. So two people with a daughter, how do they go through as the child grows? How do you play? So there are some group activities, asking questions, what ought to be done to stimulate growth, etc., how to look after, giving these sort of imagery snapshots for the people to see. So this is not an optimal environment to raise children. Not telling them to start family planning. Not telling them to start limiting their number of children. Just saying, start concentrating on child rearing. Childbearing will get in the background automatically. Because from the Thinking Healthy program originally, we also saw that the women who got the intervention, they started paying more attention towards family planning, birth spacing. And there were no messages, direct messages about family planning as such. So we thought that once you turn towards child rearing, childbearing starts getting into the background. So it's a kind of a subliminal slip to the thing. So because you can't sell, from where I come, you just can't sell and say that you need to have 2 children, 1 child, limit your, so it's failed. So we are struggling with that area as well. So having addressed this this barrier of human resource, going into the realm of peers, volunteering people. So another challenge of scaling up evidence-based interventions is that it's not possible for Siham to train a cadre of 125,000 lady health workers, supervise them. It's just not possible. Yeah. So how do I do that? So the technology comes in. We have been exploring peer volunteers. We've also explored family networks, yet for another mental health issue, child intellectual disability as well as child disabilities. So in the community, harnessing this, this human resource in the form of family networks to address, this is another Grand Challenges Canada funded project. Our organization has recently put up proof of concept that family networks, if you train these parents to help other parents, so it's a parent skills training program, but led by parents through a completely technologized intervention material. So this is a tablet which holds screening tools, which holds sessions that the family champion, which is called as family champion, who takes on this voluntary work that I have a child with disability. I will do this for other parents with children who have disability. But running through all the intervention is delivered through tablets. You can chart, you can monitor the progress. It's all server-based through just one interface of this tablet. So we thought that this was a neat way of not only harnessing this human resource in the form of non-mental health professionals, but also using technology interface. So what did we learn? We learned this and applied this to the maternal mental health context. Again, Asha is part of that another project funded by the Grand Challenges Canada. It's set in a humanitarian context where mental health needs escalate exponentially. The mothers are the most vulnerable people. They're the last ones to receive any help in humanitarian settings. So how do you, so fragile health systems, weak health systems. So this was a neat opportunity for us to adapt the Thinking Healthy program onto a technology-assisted way of delivering the intervention. Not only delivering, but training, as well as supervising the lady health workers. It is work in progress. I'll talk about a little more about this. So what do we do is, how do we detect? We detect through circulating this pamphlet. There is a interactive voice recorded system based on a toll-free number. These pamphlets are spread out. It just says that happy mother, happy child, happy family. So mother's health is directly linked to child's health. So if you feel that you're stressed, call this number and then we will reach out with help. So this is a toll-free number. When these pamphlets are spread, people start calling in. We host this on a server. So these are actually the calls that were, it's in testing phase. It's not gone into the implementation phase yet. So it's work in progress. So our web portal to hold and host these IVR calls is working. This is the, and we're using two screening Woolies questions. Loss of interest in the last 30 days, low mood in the last 30 days. So that's our screening tool to detect probable stress, mental health issues in pregnant women. And we've also started converting the original Thinking Healthy program onto this multimedia tablet-based format. So these days, our team, the tech team, is doing this work. So they're converting all the material into this sort of materials. This would have a voiceover. So this particular project does what? This will aim to have a multimedia-based training manual, supervisory manual for the lady health workers and for her supervisor. So you just put the tablet in the hand of the lady health supervisor. This will walk you through how to train. So there will be voiceovers. So this is a group where the lady health supervisor is training the lady health workers, sitting in a group. We have certain characters which keep popping up in the video. They leave some messages. So this particular character, which we like to call avatar, we're slightly pendulating between calling this avatar assisted or just simply tech assisted. So we'll keep you posted with the kind of terminology that we end up calling it.
There's an early word for avatar?
No, there's no word. Yeah. So this is a doctor or a female medical technician, which the lady health workers very easily relate to. So she, and pardon me again, all in Urdu, We're getting to the English version very soon once the Urdu version is done. So she's just talking about three basic areas. So maternal health, the maternal and child interaction and bonding is a key area, and then her relationship with the other significant others in the house. So these are the three basic pillars, the three basic spheres, the three basic underpinnings for the Thinking Healthy program. Yeah? And this goes on. So this is a three-step approach of identifying unhealthy thinking. This is step 2, trying to replace that unhealthy way of thinking with some positive or better ways of thinking, and then trying to rehearse. So behavioral activation. So this is some underpinnings with cognitive behavioral techniques. So it's heavily underpinned with that, and use of images, etc. And then this voiceover goes on, talking about how unhelpful thinking sets in if you're depressed. I'm not a good enough mom. I feel so worried all the time. I can't cope up with the needs of the child. What am I going to do? So there's this perpetuation. So this voiceover is trying to train and orient the lady health workers what it entails. So what's the natural progression of such way of thinking? And then this is an actual lady health worker delivering a session. And this bulb, wherever this bulb would come, this means an activity. So this activity is basically what you've learned right now. Let's do a role play. So the lady health workers would do a role play. One would become the mother-in-law, one would become the depressed mom, and the third would become the person who's going to deliver. And we'll be monitoring, we'll be rating, we'll be comparing this with mental health professional, a specialist-led training. So we want to compare what the costs are, what the competencies are achieved. And again, Brandon's work features heavily here. So we'll be using one of his competency checklists, which is called ENACT. So we'll compare what does a charismatic trainer entail versus this tablet interface. So some neat things in the making. And we'll keep you posted as this progresses. So it's not gone into the implementation phase. This is in its development phase. Last but not the least, almost done. So you can't do away or address maternal mental health needs in families. Back in Pakistan, back in any developing country context, health managers, policymakers will not rally up to this idea of having a vertical program separately dealing with just one of the public health issues. They've got vaccination on their hand, they've got limited funds to pick up things. So what's the solution? The solution is integration. So you have to integrate maternal mental health agenda into mother and child health agenda. And there is lots of debate around this. What are we doing? We're doing exactly that. So this is another program funded by the Wellcome Trust. Has 2 sites. It's led by Professor Betty Kirkwood along with Professor Arthur Rahman. It has 2 sites, one in India, one in Pakistan. This intervention has 3 basic components. It has maternal psychosocial well-being, integrated with child nutrition, integrated with early child development. So stimulation, so it is full throttle in its implementation phase. We are in our follow-up phase of assessment. So key outcomes being child development, cognitive development, anthropometry, maternal mental health. So again, 2 sites. And this maternal psychosocial well-being has its origins in the Thinking Healthy program. So it's an adapted version to help wrap around this way of engaging with the families, the principles of Thinking Healthy program, empathic listening, problem solving, lots of images, lots of behavioral activation, all delivered through the existing Lady Health Worker program. Because we want this to be, from the outset, sustainable, scalable. We're struggling. The Lady Health Workers, as I told you, are overburdened. But it's in its implementation phase. Now we're into our evaluation phase. So this is just some the counseling cards that the Lady Health Workers use. So the narrative is that with the family, the Lady Health Worker shows this. Do you want your children to win cups? Yeah. The shining stars come first in everything in life they do. Who would rally up to that? Even the mother-in-laws as well, who at times have a friction with their daughters-in-law. Huh? So, and from the outset, if you agree, then we need to start working from pregnancy. You need to look after, you need to provide support, work as a team. And then this goes on. So this is from antenatal till 2 years of infancy. This program rolls out through the Lady Health Workers. So lots of responsive feeding, hygiene, all integrated with the existing Lady Health Worker program messages so that she does not miss out when she's going for her visit. So she does this, what we call back in Pakistan, Roshan Kal. In Urdu, Roshan Kal means a brighter tomorrow. Yeah? So, so that's spring or Roshan Kal in Pakistan. So it's all integrated. So what's in conclusion, maternal depression is a global public health priority. There are interventions which have shown effectiveness. There are some barriers. These barriers are potentially surmountable through task shifting, through use of technology, and through integrating interventions into existing health programs such as maternal and child health programs. And I'm very optimistic. The kind of work that I am involved in, either with youth or with Liverpool or with London School, this is all very promising. So thank you very much for your attention. So Asha, happy to, any questions, any comments, suggestions? And we'll take questions, and I'd like that you all also pitch in. Yeah. So, yes, please.
I'm just curious of what type of person comes to you to become a Lady Health Worker?
Great question. The selection criteria of Lady Health Workers in Pakistan has been at least 8 to 10 years of education. So 8 or 10 grades passed. So we, majority of them are of that, but some have also up to 12 years of education. So they go through a 15 months of training, in which 1 year is classroom, 3 months is all field, hand-holding, supervising them in the field. So they're supervised by lady health supervisors, who's slightly more educated, but these lady health workers come from the same community in which they reside. So they're known, they have very intimate knowledge, so she's supposed to be looking after a catchment area of about 1,200 to 1,500, which, so there would be some patches which are slightly, so that's a lot, that's a lot. And keeping in mind that bent out of shape trucks, 25 stipulated things that she has to do, so she's slightly bent out of shape.
Would this normally be someone who's a little bit older that doesn't have young children herself?
This program was established, I think, about 18 years back. back then they had, they even had unmarried girls, but the preference was married women. Because in our context, married women shy away, feel awkward talking to unmarried women about childbirth, contraception, so it's just an awkward barrier. So majority of them now, yes, they're all married, they have children. In fact, now since we haven't had more recruitment, so this lady health worker program is called the aging cadre. So they are now aging, and we're not replacing them because of certain political issues, etc. in Pakistan. Hope that answers your question.
Yeah.
Yes, please.
This is a great program of research. I really believe in two of your three pillars: technology and integration in the primary healthcare system. Very skeptical about volunteers, pure volunteers. I think some people might say it rolls back efforts to get community health workers paid. But I'm willing to set that aside. I'm more focused, my skepticism comes more from actual implementation. I'd like to hear maybe a little bit about how you'll study this. I think it would be very interesting to see sort of what turnover rates you have compared to what incentives you could provide. I'm not sure sort of motivating encouragement goes that far. So how much travel reimbursement do you need to provide to keep someone from turning over? Sort of what does that curve look like? Because I don't think there's a lot of evidence right now that would suggest that volunteers could be successful in the long term. Maybe in a small study, but I don't know about scaling up. So an interesting question would be, if you put some money into it, at what point does that start to have some inflection?
Great question. Great question. And trust me when I say this, looking at the Lady Health Worker program, struggling with so many things for so many years, we were quite skeptical about this peer volunteers, not salaried. But what when I mentioned Ed Fisher's group, he's leading this initiative by the name of Peers for Progress. We were quite reassured that people have been using peers for a number of things, and the evidence is now coming up. The organization, correct me if I'm wrong, Ed, you're trying to build that evidence repository for multiple issues like diabetes, management of chronic pain. So they've been used for a number of years. So the evidence is coming up. So one, not having evidence does not mean that it's not effective. So it's building up. Now coming to our peer volunteers who are delivering this maternal mental health intervention, it's in its implementation phase. We have 45 peer volunteers, which we've trained last year, July. They had that embedding period, like a kind of a clinical internship, supervised, handheld, and then they were given their caseload. Since last year, out of the 45, we just had about 4 people who left because their life circumstances changed. One of them had to leave because her husband was going abroad, so she had to relocate. So, and 3 of them, prior to leaving, not us asking them, they handed their replacement. With the idea that this woman, who's extremely depressed, worried, struggling, distressed, she gets this much of respite, perhaps from my side. This should not get discontinued. So we're noting down all these anecdotal things. The flip side of it is, now we see lots of lady health workers being accompanied in the polio campaigns. Now, polio campaign, Pakistan is one of the countries which unfortunately is exporting polio. And it's a huge international issue for us. And we are hell-bent to eradicate this. And then there is this element which has been, trying to create this instability by shooting down lady health workers, terrorizing them. So, lady health workers going out for polio campaign, doing polio drops, they're shook up. We see peer volunteers accompanying them, chaperoning them. We've also we see some cases where the peer volunteers are accompanying pregnant women for their antenatal checkups. So I see lots of task sharing coming along, and this thing getting gelled. Third thing that you said about incentives, about motivation, we are going to be doing a piece to see what, because this is community, we went there, we trained them, raised their capacity, they've become slightly more prominent, it's raised their status within their community. We know from our original Thinking Healthy, a few of the lady health workers that we trained went on to better jobs. They quit the program because they had become better communicators. So their capacity sort of, got harnessed better. So we want to do a piece with ShareChild to see them longitudinally. What does this do to this community, this group of people who get their capacities developed? What does it do to them? What is it the gain that they, all non-monetary? The travel allowance, we've, for this particular project, for Share, because it's a control, you can control as much as you can control. Yeah. So, but we've tried to figure out clusters in a way that the peer volunteers don't have to commute unnecessarily out of their main residing area. The ones who do have to, we pay them travel allowance, which they receive very with an awkward smile that you don't need to do that. So today I'm supporting someone, I may need the same support. So there's lots of altruistic element and underpinnings running. So that just gives me lots of reassurance. But you're absolutely right. Retention, turnover, as I said in my talk, this global meeting that I attended, just two things. Retention, motivation is linked. And how do you link these people with the existing health systems, not to create a parallel one?
If I could add one more thing, I think it's really important to realize and understand within our setting what is important for the people who are working within the settings. For peer volunteers, being motivated, being given settings or situations in which they can build up their capacity to move onwards for a better future is one of the biggest incentives themselves.
And we want to do a piece, a qualitative piece. Follow them up longitudinally, see what this does.
I think it's okay for turnover. I think you got to expect it. People moving on to something better as well. But I'm also curious about how many complete cases they could say do in a year. Like since Thinking Healthy is several sessions.
That's a brilliant question, and we're keeping that dose. We're monitoring, we're logging the whole works, the process. We're looking at it.
Interesting.
And yes, and that's where we think that this is an innovative. So I think perhaps this in Jharkhand and Orissa, Anthony Costello, I don't know if you're familiar with his work. So he put together these women's groups, and this was a longish program. And about 3 years down the line, and there was no content. The women just sat together. Child mortality started going down because they started communicating. What's your child? What do you do? Oh, this happened. I did this. I went to. So this knowledge started spreading, and then they also saw that the mental health also started, picking up, and all done by just a volunteer who would just seat everybody together, just sit down, chat. Yeah, very unstructured. So there is evidence of peers. Ed, you wanted to add something?
Yeah. Two comments. One is, in addition to all the good things you said, the village health volunteers in Thailand, of course, are a tremendous model for this. They've been active since 1968 in the Thai health system. I've met village health volunteers who've been village health volunteers for 30 years. And so there's, clearly a model for this kind of long-term, enduring, voluntary structure. To me, as in so many areas of behavioral science, the all or none question, that catches our attention, does it work, doesn't it work, is less interesting than the more interactive question. So you've got the lady health lady health workers, you've got volunteers. The interesting questions are how they work together, who can do what better, how they reinforce each other, and that those are the system kinds of issues that will really propel us forward, rather than trying to do a meta-analysis and come to a conclusion that volunteers do or don't work. That's not a useful question.
And we're doing the same. We want to see how the lady health supervisors, the lady health workers, the existing governmental system is perceiving and interacting. What are the gains on the government side of things? What are the gains in the community side? When I say community, I am talking with peers. Yeah. So we're quite excited about this, and we feel that for mental health, for non-mental health professionals, we're slightly pushing this into the realm of this untapped human resource. Absolutely untapped. Hope that answers your question. Yes, Ed.
Yes, it's sort of pertinent to that last one. One of my favorite paragraphs out of all the work that you all have done is that from Atif Rahman's paper 2007, where he talked about the lady health worker who helped a woman buy a goat.
Lovely, yes.
And helping her buy a goat reduced her economic distress, improved her mood. That was part of the Thinking Healthy. To me, it's really important because volunteers, peer supporters, community health workers are very good, clever, real-world problem solvers.
Oh, yes.
And I'm wondering to what extent at this point you feel that emphasizing clever real-world problem solving versus cognitive restructuring a la Aaron Beck is really the critical component.
Great question, Ed. We learned from our Thinking Healthy program that it wasn't more cognitive restructuring. It was more behavioral activation, this befriending thing, empathic listening, this interaction that worked for most of the women. We didn't have funds to do a detailed process evaluation for the Thinking Healthy program. But we're quite flexible in the, if you like to use the term fidelity. So we're quite flexible, and we're noting down what is the extra things that these peers end up doing outside what was trained or what was given or which was sort of mandated for them to do. I just gave you an example. We never this peer-delivered Thinking Healthy program does not say that you accompany women for antenatal checkups or accompany in the polio campaign. There is a similar example. I think she gave a hen or something to help the nutritional aspect, so eggs, etc. So we have these anecdotal things, and we want to systematically document and study these things. So yeah, absolutely, I agree, and we're trying to do that, trying to see where your boundaries end and where this street wisdom. They're from the same culture. They've seen the same kind of issues, so they can think through these problems. And problem solving is one of the key ingredients in the intervention. Yes, Brent.
One more. So I'm really interested in the idea of how the issue of scaling up at the global level, how you consider that. We're taking the Thinking Healthy program as an example with 2008 study, initial positive results, Mark Van Ormer and WHO taking this up and saying we're going to make this a brief intervention and then packaging it and sending out to the world. And then you and Asha getting these results and saying, okay, this is a start, but in and of itself is not complete. So, and Mark Van Ormer, WHO has said, at this point we have no funding, we're a publishing house. Okay, that they're not generating the research. So these things are getting sent out, same thing with NIH gap, where there's not actual low-income country research to support that.
Yeah, that's a gap. That's a huge gap. And I've had the fortune of sitting with Shekhar, who's and I've listened to Atif and Shekhar talk, and what are the sort of gaps. But interestingly, yes, they're just a publishing house. But interestingly, some countries have already taken this up. So Vietnam is one. So Jane Fisher is leading and replicating this there. It's been taken up. One of Atif's colleagues in China, in one of the countries in Africa. So people have started and adapting this to their context. So and hence WHO also then features in. So it just helps further their cause. So I don't know how they see this in actually helping other developing countries to have this part of their policy, have this integrated in their MCH programs. I think that's a huge gap. I don't have the answer. I've sat through at least Pakistan's next 5 years planning of MCH. We pushed this maternal mental health agenda. We said that if you're not up for thinking healthy program as such, so look at Spring. It's all evidence-based. It takes into account care for development package developed by the UNICEF and WHO. So it's all contextualized, but all the underpinnings are there. So it's already evidence-based. All that we're doing is we're trying to test it at scale. So take it, integrate it. So pushing that agenda, I don't have an answer, Brendan, at the moment. And how does WHO play into all of this global implementation? So
I think we're out of time. If you have any other questions, I'm sure Siham could answer them, but thank you very much.